Thank you, Professor Lee, for your kind introduction. Good afternoon, everyone. It's my pleasure to present my recent work in evaluating local regional therapy response in HCC updates on direct radiation treatment response agonism. I'm now a attending physician in the TSGH and just finished my visiting scholar in Stanford University. And a great part of my talk today is about my research work at Stanford. There are two types of mainstream therapy for HCC, the non-radiation and the radiation one. Non-radiation treatment like TACE and the thermal ablation, which will induce immediate tumor death. But in the other side, radiation therapy like TARE, SBRT, EBRT, which will cause tumor death by two mechanisms, cellular synthesis and apoptosis. And these two mechanisms may lead to delayed tumor death. Here is a case of here is a case of a delayed tumor death presented in the image follow-up. Here is a case of CC in the segment 4A of a liver, as presented here. And 3 months after the SBRT treatment, you can see there is still intralesional enhancement within the treatment cavity. And also present of parenchyma perfusion change, which is quite common after radiation-based treatment. And 6 months after SBRT, the intralesional enhancement disappeared, and the parenchyma perfusion change persists. This is a good example to tell us that the enhancing part may indicate delayed tumor death, and it may decrease over time. And it's an important part of which is the premature classification mentioned in many articles. If you only decide your treatment response only on one single follow-up image, you may lead to unnecessary intervention because this enhancement may resolve spontaneously over the time. Now we all understand the delayed tumor death may present in the follow-up image. The next question is, can current evaluation methods predict patient prognosis? A study just published in European Radiology this year aims to predict patient survival, HCC patient survival receiving E319. And then they found that RECIST, NRECIST, and the LRTRA V2018 all fail to predict progression-free survival in this patient. Now we understand there are some limitation of our current evaluation method. So what is the newer version one? ACR, American College of Radiology, issued a LIRACE radiation treatment response agonism V2024 in the last year, which focused on the treatment response evaluation after radiation-based treatment, including E319 and the SBRT, EBRT. This agonism applies the treated lesion as 3 major categories. If there is no any mass-like enhancement, it should be LRTR non-variable. And if the mass-like enhancement is stable or decreased in size, which should be LRTR non-progressing. And if the mass-like enhancement is new or increased in size over time, it should be LRTR variable. Also, in the LRTRA, also they use the ancillary feature to upgrade lesion from LRTR non-progressing to LRTR variable. The ancillary feature focuses on the diffusion restriction or mild to moderate T2 hyperintensity, which is new or increased over the time after local regional treatment. And the diffusion and this ancillary feature should only apply to the area of stable or decreased mass-like enhancement. It's an important part because after radiation treatment, if tumor necrosis occurs, it should be T2 hyperintensity in MRI study, as everyone knows. So this mild to moderate T2 hyperintensity or diffusion restriction can only apply to the area with mass-like enhancement. Only all of 2 factors occur. You can upgrade your lesion from LRTR non-progressing to LRTR variable. Now we can see the older version of the LIRACE treatment response agonism, which is published in 2018. They only classify the lesion as LRTR variable, LRTR equivocal, and LRTR non-variable. And for the LRTR variable in the older version, any mass-like enhancement will be categorized as this category, which means no matter you are new or no matter you are progressed or you are stable or you are decreased in enhancement, they are all belong to LRTR variable, and no any enhancement is LRTR non-variable, and you are not really sure, you can assign its LRTR equivocal. Let's see the comparison of the NRECIST LRTRA V2018 and the LRTRA radiation V2024. After radiation treatment, the enhancement may progress or stable or decrease in size or vanished, and which is the progressive disease, stable disease, partial response, and complete response in the NRECIST we're all familiar with. And in the older version of LRTRA, they only assign it as variable, non-variable, and equivocal when you are not so sure. And in the newer version, LRTRA radiation V2024, the definition of variable is narrowed to new or increased mass-like enhancement. And if your enhancement is stable in size or decreased in size, it should be a new category, LRTR non-progressive. Because some terminology I use in this topic may be confusing to the audience which is not so familiar with the light rays, I just draw a simple algorithm to outline the light ray history. In 2018, the light rays V2018 CT MRI menu, there are many chapters. And in chapter A, it talks about the diagnosis category, which assigns the risk of HCC to the observed lesion, which is LR4, LR5, LRTIV, LRN, all are familiar with. And in the chapter 9, which is focused on the treatment response, it assigns LRTR variable, equivocal, and non-variable to the treated HCC for after any type of treatment. And through the time, everyone knows that when we cannot use a same algorithm to all treatment, especially for the delayed tumor death, which will occur after the radiation-based treatment. So in 2024, ACR issued a newer version. This newer version only focuses on the treatment response, and it divides it into two categories, radiation TRA V2024 and non-radiation TRA V2024. For radiation TRA, you can only use in patients receiving E19 SBRT or EBRT. And if the patient receives microwave RFA test or surgery, it can be applied to non-radiation TRA V2024. So today, if you want to use light rays, you still use the V2018 to classify the risk of HCC of your target lesion. However, if you are focused on the treatment response, you should download a newer version, which is the radiation TRA or non-radiation TRA V2024, which is in the website of the ACR. Here, this is the study I conducted in Stanford University, which is a retrospective single institution study, and we focus on the category distribution and the short-term outcome of patients receiving E19 with the newer light ray CT MRI radiation TRA V2024. We enrolled patients receiving TRE between 2011 to 2022 and include patients with non-HCC malignancy, concurrent non-radiation local regional therapy, concurrent systemic therapy, and the patients without post-treatment liver CT MRI. And we also exclude 2 patients who had LRN lesion without histopathology proof. Finally, we enrolled 242 patients with 319 treated HCC lesions. Here is the category redistribution. You can see in the first follow-up, in VISU 2018, we assigned nearly 90% of the lesion as LRTR variable, which means this, if you assign 9 of 10 of your target lesions to just one category, which means the algorithm is not too discriminative because you cannot differentiate the differences between the categories, right? So in V2024, we found that 55% of the LRTR variable in V2018 was reassigned as LRTR non-progressive in our new version, and only 42% of the variable lesion remain LRTR variable in the new version. After that, we want to know the category change in the second follow-up. For the LRTR non-variable in the first follow-up, there are 9 lesions had second follow-up, and all of them remain LRTR non-variable. For the non-progressive, which is the people are interested in because it's a newly proposed category. There are 96 lesions has second follow-up, and 65% of them remain non-progressing, and 19% of them regress to non-viable, and only 14% of them progress to viable. For patients for the LRTR viable in the first follow-up, there are 29 lesions had the second follow-up, and nearly 80% of them remain LRTR viable, and only 20% of them regress to LRTR non-progressing. Here is an example of LRTR non-progressing. It's a 79-year-old woman with HCC due to cirrhosis of liver. There is a typical HCC in the segment 7 of liver, and after the E319 treatment at the first follow-up, you can see the enhancing part decrease in size. So it should be a LRTR non-progressing in V2024, and the LRTR variable in the V2018. And in the second follow-up, the enhancing part is vanished, and which means the lesion is complete response in a resist category. So it was LRTR non-viable and in both versions. So this case told us that the enhancing part may spontaneously resolve following the time. So if you just judge your treatment response only on one follow-up image, you may lead to unnecessary treatment like test or systemic therapy. Here is another sample to demonstrate how can we apply the ancillary feature in the LRTRA. It is a 66-year-old man with HCC due to HCV-related liver cirrhosis. And before the E319 treatment, there is an arterial enhancing lesion outside the previous treated lung. And after the E319 treatment, you can see the enhancing part is decreased, which should be LRTR non-progressing, just depend on the dynamic phase. But when we go into the DWI sequence, you can also see a mild diffusion restriction here, which means if you also see the DWI image, you can upgrade the non-progressing lesion to LRTR variable due to presence of diffusion restriction in the enhancement area. At the second follow-up, you can see there is an enhancing part in the previous treatment zone, which is not observed in the pre-treatment image. So which is a new mask-like enhancement. So if we use the LRTR category, it should be a LRTR variable in both V2024 and V2018. And also you can see a local invasion of the HCC to the abdomen wall. So when we go back to the first follow-up image, you can see if we just judge the lesion only depend on arterial phase, which should be LRTR non-progressing, which means your treatment may be effective. But when we go to a diffusion restriction, you can see that the diffusion restriction in the corresponding area indicates hypercellularity. So enhancement with hypercellularity indicates the probability of viable tumor increase. So it's the reason why we upgrade this lesion from non-progressing to viable. This is the key concept of the ancillary feature of the LRTRA. In our study, the new version of LRTR algorithm also reflects a significant overall survival difference. For patients with LRTR non-progressing, they had a longer overall survival than patients with LRTR viable, with a significant difference. The highlight of our study is that the LRTRA radiation V2024 is more discriminative than V2018 because in 2018, nearly 90% of treated lesions were assigned as LRTR viable. However, 55% of them was reclassified as LRTR non-progressing in newer version. And in our study, LRTR viable indicates poor prognosis because 79% of the lesions remain viable in the second follow-up. So for these lesions, additional treatment should be considered. For LRTR non-progressing, they have a better prognosis because only 14% of them progress to LRTR viable in the second follow-up, and close surveillance rather than additional treatment is a reasonable management. My take-home message is delayed tumor death after radiation treatment complicate the treatment response evaluation, and the LRTRA radiation V2024 gives us a useful tool to evaluate the HCC treated by E319 and the SBRT, EBRT. And the newly proposed LRTR non-progressing category indicates better prognosis than LRTR viable. And in this category, close surveillance rather than additional treatment may be a better option for these patients. Thank you for your attention.